Immunomodulatory therapy basically includes thalidomide, lenalidomide, and pomalidomide, and this has been the standard of care for a while right now. So most myeloma patients undergo autologous stem cell transplant with high-dose melphalan and induction therapy previously, and then after that you do the autologous stem cell transplant and then you start immunomodulatory maintenance. And the reason behind that is to keep basically the myeloma at bay, because after transplant there is a high chance of relapse. However, giving lenalidomide, thalidomide, or pomalidomide actually reduces the risk of relapse by suppressing myeloma. What we found so far is basically at the research level. However, we do believe that it has huge clinical implications. So when we see a myeloma patient with clonal hematopoiesis, we now predict that they're going to have a worse outcome. However, in those who are receiving IMiD maintenance or immunomodulatory maintenance, the outcome is much better. So we think that for the time being, at the research level, we could start screening for clonal hematopoiesis in newly diagnosed myeloma before starting any therapy. And with time, we could monitor any clonal progression of the CHIP clone and see if there is any change in response depending on if you have CHIP or not. And for the time being, we're still trying to understand at the cellular level what's happening, because we believe that there is some sort of interaction between CHIP clones and myeloma in the bone marrow. And with the presence of immunomodulatory therapy, this interaction is probably being inhibited and but in turn not allowing myeloma to grow at a faster rate. So even though there is huge clinical implications right now, but we believe that we still need a bit more research to understand what's actually happening before we start making any recommendations in terms of the clinical setting.